Now I'd like to call upon Member Bob Gleason, who is going to introduce our program.
Thank you. It's my honor today to introduce today's speaker, John Torinus. For 20 years, John has been a tireless advocate for health cost containment by promoting both health-conscious health consumption and better health for workers and their families. Using his company Serigraph as an incubator for his ideas, he has focused on cost control, wellness, prevention, and end-of-life planning with proven results. His ideas truly do yield positive results. John brings the same energy to healthcare improvement that prompted him to ride across America at age 71 and drives him to ski the Birkie today. Well, not today, but in a few months. His ideas are captured in 2 books he's written, one in 2010, The Company That Solved Healthcare, and one in 2014 on the same topic. I look forward to hearing his proven ideas to control healthcare costs. Thank you.
Back when I was the business editor of the Sentinel, I used to do a lot of talks to Rotary clubs on economic development. A lot of rubber chicken. Food is good today. And one of my challenges at Rotary clubs was always to make sure the old cockers didn't take a nap while I was speaking. They're usually in the front row. And what I'd do is I'd look them squarely in the eye, look around, then I look right at them. And they couldn't get their nap. They get really grumpy. I'm watching you, Schuster. I'm watching you, Haig. Okay, so journalists, like I spent a big chunk of my career in journalism, and you're always looking for the catchy lead. So my lead today is this. There's a point to that. So it's 5 months old now. It's still a little cranky. I'm golfing. I'm not shooting my age yet. I'm getting close. Riding my bike, and I plan to ski the half Birkie in 5 months. So, but more to the point than my experiences with my own knee is that I bought it for $26,000 at the top-rated bone shop in the United States, namely the Orthopedic Hospital of Wisconsin. Now, there are several noteworthy aspects to that price tag. One, it's a bundled bill, all in, no other bills. It's a complete price, except for the rehab charges at another facility. Call it a fixed price versus the a la carte kind of pricing that prevails in American medicine today. No surprises, totally transparent transaction. Fixed price, one price. Everybody can understand it. Can anybody understand their health care bills when they get them? Raise your hand if you can understand your health care bills. I don't see a hand in the air. The second thing notable, it's a low price. The range in the Milwaukee market for joint replacements is my $26,000 at the bottom, ranging up as high as $90,000. The median's about $47,500. And so I will ask you this, how can prices range by 400% in any market? You tell me. It's my definition of economic chaos. The third point is I got a lot of value for my $26,000. This is a facility with almost no infections, very low infection rate. I got a warranty on the surgery, so if there was a readmit, they don't charge me double for it. And most of medicine today, if you get an infection, you go in, they treat your infection, you got to pay for the infection they gave you. If I tried that at my manufacturing company, I sent some bad parts to Ford, and I tried to charge them for the second batch of parts. I don't think I'd get away with it. In fact, I get penalized if I ship bad parts. So there is good evidence today from my experience, which was a good experience, no readmits, that there's an inverse correlation between price and quality. There's a direct correlation, incidentally, between volume and quality. The more surgeries a guy does, the better he gets at it. But there's an inverse correlation on price and quality, just like there is in manufacturing. The better the quality, the lower the waste, the fewer the defects, the lower the costs, the lower the prices. So I say to you, in all seriousness, if you're going to go get a coronary arterial bypass, get the cheapest one you can find. And there's some studies out there that are showing that correlation. Y-axis, x-axis, and the good guys are up in the upper left corner, low price, high quality. So you didn't come here today to hear about microeconomics, which is what I've been doing, because you guys are big picture guys. So I'm going to try to go from the micro to the macro, and let me try to make the case that what's happening down at the ground level, at the micro level with my knee, informs what should be happening in the national debate. I think we can all agree that the political leadership in this country is stuck in the mud when it comes to healthcare reform, should I say in the swamp. So they're just coming up short as they try to come up with a meaningful reform. Obamacare, which was a noble attempt, came up short of its ambitious goals. It did add coverage for about 16 million Americans, but there's still 28 million out there without insurance, without coverage. And the affordable part of the Affordable Care Act proved anything but. It was designed by wonks who had probably never paid a group health care bill. By the way, I always start my speeches, the last thing I remind myself, be nice, but I don't think so. These guys probably can't balance their checkbook. So the premiums and the deductibles before Obamacare which went into effect in 2014, have doubled since then. Deductibles doubled, premiums doubled, and they're still rising quickly. In short, the Democrats didn't lay a glove on inflating health costs, the biggest single economic issue in the United States. It is just as obvious that the Republicans have no red print to correct the Democrats' blueprint, even though the GOP has many friends in the business world, like myself, who have developed innovations that have contained the medical inflation rate in the private sector to 3%. Now, mind you, we've been galloping along at what I would call hyperinflation in healthcare for about 4 decades, up 7–8% a year, doubles every 8 years. And now we've got it down to 3% in the private sector. Something is going on in the private sector, and it ain't ACA. So the success in the private sector gives some insight to this national crisis we're facing. And by the way, I think it is a crisis when medical costs take about $5,000 out of every American home, the excess medical costs. It's about $20,000 a home right now, and probably $5,000 of that is excessive. So what that tells me is that political science is not up to solving this problem. The real challenge, it seems to me, is to bring management science to bear, which is what's going on in the private sector. Costs, access, quality service, they all add up to value. And all of those aspects can be managed. The emphasis here is on management, which is the missing link. So what I'm going to suggest in my short time today is that why not restart the national reform debate with stuff that works as opposed to stuff that didn't work. What didn't work under ACA was a major expansion of Medicaid. Obviously, we still have 28 million uncovered. The cooperatives, there were 28 of them funded by the government, 26 are gone. The mandates, exchanges, penalties, and prosecutions by the IRS are not working. Similarly, the GOP attempts to reconstitute, to repeal and replace ACA are probably going to crash and burn in Congress this week. So in the aftermath, doesn't it make sense that we have some fresh ideas brought to bear? I always remember the Marine invasion in Incheon. They couldn't go straight against the Chinese. They went around them, they enveloped and came in from the rear. So I think we have to come at this national crisis in new ways. And fortunately, I'm going to suggest today that there are 3 effective platforms that could form a national program and should be politically acceptable on a bipartisan basis. These 3 platforms are not a big stretch because they're already happening at the ground level at companies like mine and yours. And when you add them all up, what's going on at the ground level, in my contention, amounts to a new business model for the delivery of care in America. And these 3 pillars today, and there are other pieces to this, of course, but I only got 20 minutes. But the 3 pieces I want to call out today are what I would call value-based healthcare driven by employers, lean transformation in hospitals and clinics, and something, a new idea that a friend who ran a lot of Medicare and Medicaid programs suggested, Medicare Advantage for not all, but for the needy. Not Medicare for all, Medicare Advantage for all, and I'll come back to that. So these 3 foundational concepts that I'm going to deal with the 3 biggest forces in the medical industrial complex. Get that word? Remember the military industrial complex? It was 5% of the economy. We now have the medical industrial complex, it's 18%. And those 3 big players are the private payers like me. Actually, if you think about it, private corporations pay the whole health care bill in the United States. It's about half the bill on the private side. We pay for that. Then we also pay the taxes. And our employees, we pay our employees' wages, they pay the taxes. That pays for the whole public half of the bill. So at the end of the day, private employers pay the whole bill in this country. So one of the pillars is the private payers. The second, of course, is the providers. And the third one is the public payers that take care of the people that need subsidies. We don't have a lot of time, so let me give you the headlines in the first 5 paragraphs on each of these pillars. The first one, value-based healthcare. About 150 million Americans are covered under their employers' health plans, about half of the population. It's working pretty well. And that's where all of the innovation in the delivery of care is coming from. And I'll just give you a couple examples. Self-insurance didn't hardly exist in the private sector 20 years ago. Today, 80% of the companies with more than 200 employees are self-insured. It's in the end zone. Game over. Secondly, consumer-driven healthcare. That's high deductibles offset by a health savings plan of some kind. 60% of the private sector employees are now on consumer-driven health plans. It's in the red zone. Proactive primary care. The present system is marked by reactive treatment of symptoms, and I'll see you the next time you have something wrong with you. But proactive primary care is sweeping through the private sector. So about 1/3 of the major corporations in America now have on-site proactive primary care. They basically said to the big providers, we don't like how you're delivering primary care, we're taking it back. We're taking back the front end of the supply chain. We're going to control the initial contact with the patients, our employees. Here in town, Northwestern Mutual Life now has 2 on-site clinics. Briggs & Stratton has 2. Quad has a bunch. Rockwell has 1. Miller Coors has 1. Steinhaufel's has 1. West Bend Mutual has 1. And then many small employers or smaller employers, medium employers like myself, have part-time clinics with a nurse practitioner. So, and then lastly, so that was about our own 20-yard line, but it's moving pretty fast. And lastly, we're moving to value-based purchasing. We're buying by the bundles. We're buying joints for $26K as opposed to 47. So all of these innovations have come from the private sector payers, guys like me. So if you flip back to the national level, Bernie Sanders would get employers out of health care in his Medicare for All vision. And Paul Ryan and some of the GOP wonks want to eliminate or reduce the employer deduction for health costs. Just let me comment just briefly on the flamboyant senator from Vermont and his plan. One thing you'll notice, he never talks about the ways and means. There's never any talk on the price tag. So I'm going to go back to micro for a minute here. So I pay about $15,000 per employee in my company. Average household income in Wisconsin is about $55,000. Do the math. That means about 27% of payroll is necessary to fund every American. So what Bernie doesn't talk about is he's going to have to add a 27% payroll tax on top of the current Social Security and Medicare tax of about 15%. So you're going to be looking probably around a 50% payroll tax to do what Bernie wants to do, which is cover everybody under Medicare. So where does that lead us? It leads me to leave employer-based health care alone and its deduction. Indeed, encourage employers to do more, such as through HSAs and FSAs. And I would commend to you that when I'm talking about this ground-up stuff, this micro stuff, the results are not trivial in the big picture. So, for instance, with 80% of the private companies now self-insured, I underwrite my own risk. I'm taking the risk. What do you do when you have risks in your company? You manage it, right? Any risk, whatever the risk. So they're out of the group insurance business in the private sector. Did you know that? Did you know the Blues, United Healthcare, do not underwrite risk in the private sector anymore? It's a massive change in the economic landscape. They've been I love the word, disintermediated. Similarly, if bundle prices take effect, single prices, all-in prices, transparent prices, they're out of the discount business. They're out of the discount network business. And so I only have about 60 bundles in my company. We go directly to the mill, directly to the supplier, to the provider, to the hospital, and cut deals. But there's a small company in town that has realized the power of this. It's called Access Health Net. Disclosure, I'm an angel investor and a board member. They're now up to 1,200 bundles, heading to 2,000. So if you get bundles on a broad range of procedures, the discounted networks go away. Again, the middlemen, the health insurers are going to be disintermediated out of one of the core pieces of their business. This is not trivial stuff. Okay, so that's sort of the private, keep the employers in the business of healthcare. Don't mess with it. The second one is lean transformation. You probably all know that Toyota invented the famous Toyota production system about 40 years ago, and they proceeded to kick butt in the auto industry until they were at the top of the global industry and still are. American manufacturers, me included, because I sell auto parts, had to scramble to catch up. What are these guys doing? And we're racing over to Japan, going through their factories, trying to figure out, well, how are they kicking our butts so bad? So it took about 20, 30 years before we figured it out. We caught up, and now it's an even playing field. You can drive your car 200,000 miles because the quality is so good. So similarly, in the healthcare industry, there are a few pioneering healthcare leaders that have spent the last decade trying to bring those same problem-solving disciplines to the healthcare industry. You'll be gratified to know that it's called lean disciplines. The lean revolution is being led here in Wisconsin, particularly by Theta Care in Appleton, and its pioneering CEO, John Toussaint. Also in the vanguard in the country are Bellin Health out of Green Bay and Gunderson Health out of La Crosse. Cleveland Clinic is one of them. There are about 60 hospitals that have now gone down this road over the last decade out of 6,000 in the country. It's happening. Appleton Memorial, which is the lead hospital in Appleton in the Theta Care system, has achieved 0 infections in their operating rooms by engaging all of their employees. Lean's about getting all of your employees, trying to drive out waste and drive out defects. And so they've done it. They've got 0 infections in their operating rooms. That, incidentally, infection rates is my surrogate metric for how is a health clinic or hospital doing on quality. If the infection rate is good, they're probably good across the board. So that's the first thing we look at. So once we find those lean hospitals, who are the high-value providers, we say to our employees, if you go there and get your surgery done, it's free. So my knee was free to me. I paid 0. And why would we do that? And we do it because, number one, it's the right thing to do. Then number two, because of the inverse correlation, we save a lot of money. So last year at Serigraph, my bill's about $5 million a year, and I saved $440,000 last year by steering to these high-value providers. Note that platforms number 1 and 2 are linked. You got the self-insured employers that are inducing innovations, and they're seeking out the high-value hospitals, which are typically using lean disciplines. Okay, platform number 3, this one's a trial balloon. I don't think I've ever heard this idea before, but I got a smart friend who said that, you know, the Medicaid expansion has been pretty messy and pretty undermanaged, but there is a program in the United States that everybody loves. Does anybody, you've ever heard anybody complain about Medicare? Ever? Everybody loves Medicare. It's popular politically on both sides of the aisle, but my friend has put a spin on it and says, what about Medicare Advantage for all? And I want to amend the all in a minute. The problem with Medicaid is that it's got 2 chefs in the kitchen. It's managed both at the federal level and at the state level. So it's almost impossible to innovate when you have to get 2 chefs to sign off on the recipe. And indeed, it's even more impossible to control the costs. If you think about it, if in a state, the feds, like Wisconsin, the feds are providing 60% of the money, California at 70%, that's a huge incentive to spend a lot of money, right? If you're only picking up 1/3 to 40% of the tab, the guys running the program in Wisconsin or California are going to say, hey, that's free money from the feds, let's bring in as much as we can. So there's also almost a built-in incentive to overspend on Medicaid. And at the same time, on the other end of the equation, Medicare reimburses so poorly that 30% of the doctors in the United States won't take a Medicaid patient, 40% won't take a new Medicaid person. As a result, poor people have a terrible time getting access, which is what this thing was all about in the beginning, getting access. So the Medicaid solution to taking care of the needy, the poor people in the country, has not worked so well. Did you know that 1 in 5 people in Wisconsin is now on Medicaid? And 1 in 4 in California is on Medicaid. By the way, that, if you could do the math, that means we're subsidizing, the red states are subsidizing the blue states, which explains part of the hang-up in Congress. The red states don't like to subsidize blue states. Further, Medicaid is killing state budgets. It's crowding out priorities like K-12 education, the University of Wisconsin, even public safety in Milwaukee. You've been hearing the debates on the radio the last couple days. In the last budget that was just signed a couple days ago in Wisconsin, the University of Wisconsin, after years of freezes, picked up $32 million. Whoop-de-doo. Medicaid's increase over the same 2 years, 2017-19, is $470 million. Medicaid is chewing up all the money that's coming into Madison and chewing up our priorities. So what the Republicans in Congress are proposing is we have 1 chef in the kitchen. They want to send the responsibility for managing Medicaid back to the state level, and they want to do it in block grants. But they also want to cap the monies coming back to the states. So they're trying to balance the federal budget at the expense of the state budgets, which is why Governor Walker is so leery about block grants coming back to Wisconsin. So it's very, very scary for future budgets. Well, it's not going to pass, so I guess it's not scary anymore. But there's a better answer. And that answer is go with a platform that works, namely Medicare. And what I didn't know is that the 30% of the Medicare recipients are now opted for Medicare Advantage. And Medicare Advantage is a program run by the health insurers, and they actually figure out a way to cut costs so they can actually add value, like vision coverage, on top of the standard Medicaid program. So Medicare works. It's a unitary system. It's a unified management system. You don't have 50 different state jurisdictions to deal with. Everybody loves it politically. The providers don't get rich on Medicare, but they don't go broke either, like they do on Medicaid. So Medicare's probably a good vehicle to ride. And now that idea has not come up in Washington over the last couple of years as this debate goes on, but I think it ought to be injected. And Bernie's injecting it, but he's injecting it at the wrong level. He wants to take care of everybody. What I'm suggesting is you take Medicare Advantage and apply it to the needy, the people using subsidies. Medicare, by the way, is into bundle purchasing. you know, even better about, if you're a Republican, or a Democrat, even better about Medicare Advantage is, number one, it's a choice program. You can go from standard Medicare to a Medicare Advantage. You can switch around on Medicare Advantage programs. You can shop. There's probably 20 of them offered in Wisconsin. That means there's competition. Competition is good. It lowers costs, and those cost savings are allowing additional benefits like vision coverage. So what's not to like about Medicare Advantage as a platform for taking care of the people that need subsidies? Get rid of Medicaid, get rid of the Obamacare exchanges, let individuals and small businesses too buy their coverage via Medicare Advantage as a replacement. So that's sort of the headlines in the first 5 paragraphs on my 3 platforms that could form the underpinnings for a better national model. So sum it up, encourage employee-based health care, leave it alone. It covers about half the population. Why would you want to mess with that? And they're doing it at better prices than the government's doing it. Number 2, reward the value providers, those lean organizations. They get the volume, they get the business. You could also add in some bonuses if you wanted to for performance. And lastly, use Medicare Advantage to provide access for the needy. This 3-way, and incidentally, this has the possibility of being bipartisan. John McCain pulled out of the Republican compromise because he said the bill going through was not bipartisan enough. He's smart enough to know that anytime you pass major society-crossing legislation, you need the country as a whole behind it. And of course, that's one of the mistakes that was made with ACA, with Obamacare. It was forced through by one party. McCain doesn't want to do that again. And so he's saying, make it bipartisan. And the program I outlined, where Medicare is at the heart of it, has that possibility of being bipartisan. It should be a workable compromise across both sides of the aisle. I'm done. As they say in the news business, 30. So I spent a lot of years asking snotty questions as a journalist, so far away. Yep. Okay, the first question was, how do you treat bundle payments when you're treating something like cancer? Well, number one, I did say that bundle payments are on the 20-yard line. So right now it's mainly orthopedics, mammograms, colonoscopies, the more standard high-volume stuff. But I see the day coming, so breast cancer 3, I've been through it in my own family, is a fairly standard procedure now. So I expect soon that breast cancer stage 3 treatment will be a standard protocol and therefore ripe for a standard price. So I think that will happen. In fact, it's in the process of happening. Ditto with cardiac stuff. I don't have any cardiac bundles yet, but I'm very close to getting them. We're also going to get them for infusion of drugs, which are, as you know, just god-awful. Incidentally, on that one, I didn't talk about it today. I've lowered our health costs $600,000 over the last 5 years from $6 million down to 5.4. I lost it all to drug price increases. I went down 600, drugs drove me back up 600. What was your second question?
How do you handle prescription drugs?
Yeah, the drug thing is a real challenge, and as I say, that one I have not figured out yet. We are doing some things. Obviously, there's a bunch of tier programs. You march people through the protocols until they get to the specialty drug. We had a little girl with epilepsy, and the drug was $178,000 for a year. You know, well, that's as much money as my company makes in a month. You know, so it's just, there's got to be a solution. And there, the government may need to step in and do price controls, because I sure don't have an answer yet. There's no real competition out there. I don't know. I don't see my way out of that. We obviously do a lot of things. We make generics free, and generics are part of the answer. We have protocols for step therapy, so you start with the lower one and move to the higher one. And we're looking for a bundled infusion center. So we're doing some things, but we're really not laying a glove on it. It's a huge problem. Yeah, it's okay. So I wasn't dealing so much with the nursing home issue, which is, you know, $7,000, $8,000, $9,000 a month. I was dealing more with the poor people that have regular health issues like the rest of the population. So that's a question. I don't, if you're paying for it under Medicaid, I don't see why you couldn't pay for it under Medicare, except that Medicare would be better managed. Well, so the question was, how do you get back to a private sector solution? And we have a private sector solution for half the population. 150 million Americans are covered by their employers. Yeah, I think you're right, though, that this country is tipped over the point. I think healthcare is now seen as a right, and I don't think you can turn the clock back on that. So therefore, you got to address the access issue, which is what Obamacare tried to address. So some way, somehow, you got to make healthcare available to every American. And I would argue that managed correct. So I'm delivering for $15,000. The numbers that just came out at the federal level from Kaiser were $22,000 per family or per employee. So I'm operating $5,000 to $7,000 below the national average. So I think if everybody were delivering at the same level, and by the way, I'm not the only company delivering at $15,000. All of the companies that I cited earlier, most of the private companies are right around that $14,000, $15,000, $16,000 level. That ain't cheap, by the way, but it's a lot lower than the federal level. So if everybody were managing that well, we could probably afford to cover everybody. But you can't have an unmanaged system, which is essentially what you got with Medicaid. Jim? Mitch Daniels, the former governor of Indiana and now president of Purdue, is taking it on. God, I wish he were president. Governor Walker made a run at taking the 65,000 state employees in Wisconsin and putting them on a self-insured plan, but got knocked out by the Republicans, go figure. So there are, really again, there's two ways of going about major societal change. You can try to impose it from the top, like President Obama did with his wonks from MIT. What was that guy's name, Gruber? The guy that thinks the American people are too stupid to understand what's going on in healthcare. That guy, that pointy-headed guy. And you can do it from the top and try to force it down, or you can do it organically from the bottom up. And I think that's what's happening in this country, is these changes at the ground level are going to be more profound at the end of the day than the failed top-down model. What was the question? I got off track, sorry. What was the question? Oh, any governmental, yeah, so, okay, I'm tracking, now I'm tracking, Jim, I'm tracking. Hang with me, here I go. So what's happening is the private sector is doing all these reforms, and the government bodies are at the local level are following suit. So the West Bend School District is now operating at $15,000. They got consumer driven, they got HSAs, they got a clinic on site. The Elmbrook schools are doing the same thing, Waukesha, Sheboygan. So local government, by the way, counties are creatures of state government. They're all doing it because the pain is so high when you get over 20 grand an employee that they got to do something. So they're doing it. They're watching what we're doing and they're doing it. So why doesn't that inform state government and federal government? That's what we're trying to do, is inform. I've tried to talk to the guys in the Beltway. They're not really good listeners. A lot of these big innovations are going on right in Wisconsin. It's like the weatherman who never sticks it's going to rain this afternoon. If he'd stick his head out the window, he'd realize it's already raining. And these guys, they're in the district. Quad Med is here. They pioneered proactive primary care. John Toussaint is pioneering lean disciplines in healthcare right here in Wisconsin. Huh? Stick your head out the window. The question was, how do you get these ideas out? And that's what I've been doing, and I think, and I think, Lori, that the ideas are getting out there. After all, 80% of the companies are now self-insured. They're doing it. They're managing their own healthcare risks. 60% of the employees in this country are now on consumer-driven plans. Some of the deductibles are way too high, so that's a problem. And some of them are not offset by an HRA or an HSA. That's a problem. But maybe the government can step in and make the rules and regs easier for HSAs and HRAs so they can go that way. But in terms of getting the message out, I think it is getting out. I almost call it a stampede towards these innovations. Proactive primary care is clearly taken over, so much so that the hospital corporations are now going, oh my God, I let my primary care customers get away from me. That'd be like you losing your banking customers when they're doing their initial transaction. It's really dumb to let your patients get away from you. And I went to these corporations at first. I said, I'm going to put in a clinic. Why don't you put it in for me? And they go, oh. I said, okay, I'll do it. And then they go, oh my God, he did it. And so, when you lose your primary care customers, that's the feeder system into the secondary and tertiary care, which is where the meter spins at a very expensive rate. So I do think the word is getting out. Of necessity, The pain is so high. This is the biggest economic issue in the United States, by far. What did Gates say when he left the Pentagon? He said, I'm now spending more money on healthcare than I am on weapons. That's a bad priority. We just, you know, when I buy polycarbonate sheet, which I print on, I go to the mill. I don't go through a distributor. I don't go through a middleman. So we just go directly to the providers and cut a deal. I started doing it about 10 years ago. Actually, the first one was Smart Choice MRI. They started offering $600 MRIs. I was their first customer. And we just kept adding them on. But I'm one medium-sized company, and I don't have a lot of clout. This company called Access has got a whole bunch of people signing up on the payer side, which allows them to sign up a whole bunch of bundles on the provider side. So this one's on our own 20, so it's just getting going. Now Medicare is doing it. They're the biggest purchaser in the country. CalPERS, the second biggest purchaser, which is the pension fund in California, is doing it. They do it in a form of a cap. It's called a reference-based price. We'll pay no more than $30,000 for a joint, no more than $3,000 for a colonoscopy. But it is moving, and it should. I mean, that's how we buy a car. That's how we buy anything. You can see the price, right? I mean, if you want to talk about just a fundamental flaw, you don't even know what the frickin' prices are. It's like getting a menu with no prices on it. Who designed that system? George, did you design that system? No. Well, as I understand it, and again, I'm just getting into the drug thing is just something I'm just starting to dive into. But as I understand it, that was exempt from when George W. Passed Medicare Part D. He, for some reason, he accepted a ban on negotiating with the drug companies. Yeah, it's Congress could change it for sure. Congress can change everything the next day. President Trump changes things the next day, every day. Well, that's what Bernie Sanders is pitching, Medicare for All. That's basically a single payer plan. And I pointed out that, yeah, we can do that, but you better reach for your wallet. You're going to be paying a 50% payroll tax to get there. And incidentally, there was a run at that in Wisconsin 10 years ago called Healthy Wisconsin. David Reamer pushed it, and Levin did an audit, and I'm probably the only guy in the state that read the audit, and I went back and way back in the footnotes, it said, yeah, it'll be a 21% payroll tax. That was 10 years ago. So it's going to, now on the other hand, we're already paying that. It's just being paid by employers and employees themselves directly, as opposed to paying taxes to the federal government and then they buy it for you. So I can see Medicare for all the needy, and specifically Medicare Advantage would be a better way to go for the needy. But why would you mess with employer-based health care on 150 million people that are generally satisfied with their health plans? In fact, I would go the other way. I'd make it easier for smaller companies to do it. Let them buy into Medicare Advantage. If you got 50 employees or less, let them buy the health care through Medicare Advantage. It's a historical act. The question is, well, how did employers get into this healthcare business? Am I motivated? $5.4 million. Why aren't the middlemen as motivated as I am? I'm writing the checks. That's my motivation. Plus, I want a healthy, productive workforce. When I was a Marine Corps officer, my Marine buddy over here would attest to it. We kept our troops fit because we wanted to be combat ready to go. Well, I want my employees to be fit too. I mean, they're going to be more productive, they're going to be happier, their morale's going to be better, I'm going to get more done. So there's all kinds of reasons beyond just the costs, which is the big reason, but beyond the cost to worry and care about the health of your workforce. Yeah, I get asked that question all the time. I'm a small business, I can't afford to put in my own clinic, bum, bum, bum. And so then again, I think this Medicare Advantage, if your employees or you could buy into Medicare Advantage, it'd be a good option for you, right? It's pretty well managed. I mean, everybody agrees that Medicare is pretty well managed. So why don't we go with I go back to the management team, management, the missing link. Medicare is well managed. Let's use it. Employers are doing a good job of managing it. Let's use it. The lean hospitals are doing a fabulous job of driving out waste and infection. So ThedaCare operates, its cost basis is about 30% below the norm for the country. So let's go with the guys that know how to manage. It's about management science, not political science. But if you're a politician, you don't know that because you've never been in the management world, or only a few of them. Most of them are lawyers. I don't want her to plagiarize this.
Thank you, John. I'm sure he'll be around a little bit in case people have additional questions.
An MCM production.